Okay, so we can start our webinar. Okay.
Right.
Good morning, Professor Aziz, and good morning, Professor Nesrine. I would like to take the opportunity to wish you and your families a happy Ramadan.
Thank you.
Yes. Thank you. Okay. Also, I would like to say hello to all the audiences online. Wish you have a good day. This is Audi from Wisonic Medical. I am now staying in the Wisonic headquarters, Shenzhen, China. I would like to welcome all the new and old friends to join the webinar series of Wisonic Dandelion College. Wisonic Dandelion College is a free online platform for the purpose of sharing the ultrasound technologies with professional and medical practitioners. Today, we're much honored to invite Professor Aziz from Egypt as our webinar speaker to share his valuable experience of updated anesthesia types for total knee replacement surgeries. Meanwhile, we are also much honored to invite Professor El-Refai as our webinar moderator. Today's webinar will be divided into two major sessions. The first session is the lecture by Professor Aziz, and the second session is Q&A. So welcome you all to raise your questions and further communicate with Professor Aziz during Q&A sessions. Now, please allow me to give you a brief introduction of our moderator, Professor El-Refai. Okay. Professor Nesrine El-Refai, she is the treasurer of the African Society for Regional Anesthesia. She is the professor of anesthesia and pain management at Cairo University. She is the member of Pan-Arab Society of Anesthesiologists. She is the former member of Anesthesia Committee of World Federation Society of Anesthesiologists from 2012 to 2020. She is the member of Education Committee of WFA since 2020. She is the instructor of Advanced Life Support in European Resuscitation Council. She is the member of Society of Airway Management of the USA and the Difficult Airway Society of the UK. Her special interests include obstetric anesthesia, difficult airway management, simulation, and advanced life support. Okay, thank you. So let's welcome Professor El-Refai. Thank you.
Thank you. Rio de Janeiro, 2006, Sydney, 2013, and Cape Town, 2014. He's examiner for the Egyptian Master and MD degree in Anesthesia, Cairo University, and primary examiner of the primary part of the Irish Fellowship exam since March 2009, and also an external examiner of the Master degree of Anesthesia at Kuala Lumpur University, Malaysia, since November 2009. His special interest in regional anesthesia, including ophthalmic anesthesia. Welcome, Professor Aziz.
Well, thank you so much. I just want to thank Wisonic because it gave me the opportunity to share my experience with my colleagues all over the world. In fact, I founded the African Society of Regional Anesthesia because, in line with Wisonic, we like to share knowledge in remote areas. And as you know, in the deprived areas like in Africa, it's pretty expensive to go abroad and share the knowledge with the people. So I think Wisonic is doing a great job by sharing the knowledge of experienced people all over the world. And you're sitting at home and you're getting just like sharing experience with with people all over the world. I just want to give you an idea about the African Society of Regional Anesthesia before we go on for our lecture.
Okay.
Just a minute. The African Society, as you know, there are 5 societies all over the world. The American Society of Regional Anesthesia, which is the oldest one, the European Society of Regional Anesthesia, which was founded in 1980. They have the Asian Oceanic Society of Regional Anesthesia, and then the Latin American Society of Regional Anesthesia, and lastly, the African Society of Regional Anesthesia. We have members from all over Africa, but mainly from North Africa and southern part of Africa. It was founded in 2010, and our head office is in Cairo, and this is our website. If you want to know what we do, it's the afzra.org. The objectives, which goes online with WISONIC, that we have a forum of discussion of new innovations in the field, Anesthesia Society. And then in 2014, we were honored to host the World Congress of Regional Anesthesia and in Cape Town, and it was the 5 societies meeting together, and it took us 4 years for preparation. And the 5th meeting, we did it in Khartoum. And just want to tell you about the World Congress of Regional Anesthesia. It happens every 4 years, and it is done by the 5 sister societies. The first one was in Barcelona by European Society. The second one by the Latin American Society was done in Rio de Janeiro. The third one by the Asian Oceanic Society of Regional Anesthesia, that was done in Sydney. The 4th one was done by the African Society in Cape Town. The 5th one was done by the American Society in New York. And the 6th one, hopefully, will be done in Europe, in Barcelona, in 2022. Now we go to our lecture.
Okay, welcome.
So just open it.
And can you make it a full screen? Because on our side, it's not a full screen.
Samy, full screen. The patient needs to be involved as early as possible in the physiotherapy, and to be involved quickly in the physiotherapy. As an anesthetist, you need to give him analgesia without motor power loss. So these are the 2 things that we have to concentrate today. How to give analgesia without motor power loss. Because if you give him good analgesia, like an epidural, for example, okay, he will be pain-free, but he will have motor weakness, and he will not have the chance to be involved as early as the surgeon wants in the physiotherapy. So actually, your way of analgesia will make a difference in the prognosis of the operation. Because, as you know, uncontrolled total knee pain will increase the sympathetic tone. There is vasoconstriction, there is increased intestinal motility, there is increased incidence of nausea and vomiting. It even downgrades the immune function, and you will have delay in discharge. As you know now, money talks, even in the health system. So if you have a patient with uncontrolled total knee pain, you will have a delay in discharge, you will increase the health care costs, and most importantly, if you don't give the patient good pain relief, you can potentiate the chronic postoperative pain syndromes. So you will have a patient ending up by chronic pain syndromes, and this will be an extra cost for the patient and on the health system. So actually, by giving a patient good analgesia, you have 2 things. You have a better prognosis for the operation, and second thing, you have a better relief for the health system, because if you have a national health service, the service will provide the care for the patient for free, and this will put extra pressure on the system. So your types of anesthesia and analgesia will make a difference to the patient. It actually affects the rates of surgical site infection, the incidence of urinary retention. You have the ileus, nausea and vomiting, and the ability of the patient, as I said, to safely participate in the early postoperative rehabilitation, which is very important for the success of the operation. So we start the analgesia before we give the anesthesia. Multimodal treatment of pain. This is a well-established system. Everybody knows it. With patient, you will have a better satisfaction scores. As you know, we have different classes of agents that work on different receptor targets. And as I said, if you poorly manage the acute pain, the patient might end up by persistent pain syndrome. He will be a chronic patient and will have lots of pressure on the system. So you will have better pain scores when you use the multimodal treatment of pain without giving the patient lots of opioids with its side effects. So we use what we call preemptive analgesia, which is the multimodal, which is the standard one. Our goal is to prevent the production of inflammatory chemicals during the painful stimulus, so you avoid the sensitization of peripheral and central nociceptions, and subsequently you will decrease the opioid intake and the patient will not have the opioid-related side effects. You wouldn't believe that if you give patients lots of morphine, he will start vomiting and nausea, and he will not be able to be involved in the early physiotherapy, even if he's pain-free, because if he's going to vomit and he's nauseating, he will not have the power to be involved as early as possible in the physiotherapy. The most common agents that we use are the non-steroidal anti-inflammatory, like COX-2 inhibitors, the gabapentin, acetaminophen, or paracetamol, and other like antidepressants or ketamine. Some centers would use this as preemptive analgesia. And we usually start our preemptive analgesia 1 to 2 hours before the surgical incision. COX-2, they're good because they don't have lots of adverse effects. There is a reduced risk of gastric ulcers. They have minimal effect on the platelet functions. And of course, if you give the patients COX-2, and there are some studies that if you use gabapentin, you would see that the flexion of the knee joints is better after 30 days. And of course, there is substantial use of a reduction of the morphine during this period. And most importantly, the incidence of chronic pain syndromes is much less 6 months after the operations with gabapentin and COX-2. This is the graph that shows that if you use paracetamol, 1 gram is as effective as 10 milligrams of IV morphines. And you have the advantage that you won't have the side effects of the opioids. And usually we started, as we said, 1 to 2 hours before the incision. These are sort of drugs that we use in the multimodal analgesia, preemptive: ketamine, ibuprofen, gabapentins, paracetamol, and they usually use 1 to 2 hours before the operation. And you can give them orally or intravenous according to the type of drugs. And as I said, it has been proven that they're very good. They reduce the consumption of opioids, and the incidence of chronic pain syndromes is far less when you use the multimodal analgesia. So this study showed that there is a significance, clinical evidence that the opioid plus another class of agents is better than opioid alone. It goes without saying, and it's quite obvious. And there's been lots of researches about this. And again, I am saying that the preemptive analgesia would decrease the incidence of usage of opioids postoperatively and the incidence of chronic pain syndromes 6 months after the operation, which is really something that we should be looking for. Then we said the preemptive analgesia before surgery. So we start by what sort of anesthesia would you give to the patients? We agreed now that 1 to 2 hours before the operation, you would give them the multimodal analgesia that we just discussed now. And then you have 2 choices of giving anesthesia for total knee replacements, either spinal or general. So what do you think which is better? With the spinal, even though there is failure rate of 4%, complication rate, hypotension, and retention are common. So these are the minor side effects of spinal. But if you give them general anesthesia, you have increased risk of pulmonary compromise. There is higher infection rate. The incidence of acute renal failure is more, and the overall 30-day mortality is far more with general than spinal anesthesia. So what would be the choice? Spinal, of course. Okay. So in a study of 14,000 patients that's been undergone total knee replacements, you have 6,000 patients received general anesthesia and 8,000 patients received spinal anesthesia. And this study showed that the patient who received spinal anesthesia, they have a statistically significant lower rates of site infections, blood transfusions, overall complications, shorter surgical time, and length of stay was much less in spinal. And as I said, this is very good because this will decrease the health cost on the National Health Service of your country. And these actually was much more noticeable in patients with higher ASA classification. So the sicker the patient, the better that you give them spinal to avoid the complication of general anesthesia. This meta-analysis as well showed that spinal anesthesia, they said that there was no difference in the mortality and chest infection, but the length of hospitality was reduced with spinal anesthesia. And as I said again, it releases the health system from pressures. That's, as you know, that sometimes you have patients who are on the waiting list to having knee replacements, and because the patient stayed 2 or 3 days more than they should, then patient can be canceled. So you have cancellation of patients because your analgesia is not the way it should be. Your kind of anesthetics was not the right one for the patient. So when you give anesthetics, I don't want you to look at the patient just that you're going to give him spinal anesthesia or whatever kind of anesthesia. I will not see him again. No, you have to know that the surgeon wants him to get involved as early as possible in the physiotherapy. So you need your analgesia mode should meet the needs of the surgeon. You are part of a system, okay? So what about, which is the topic of our talk now, what is the post-operative pain relief, okay? As I said again, the most important goal that we want to give the patient analgesia without motor power loss. This is our goal as an anesthetist in knee replacements, because if you don't get the patient as early involved in the physiotherapy as early as you should, then you are a failure anesthetist, okay? Because this will affect the prognosis of the operation. You're putting pressure on the health system, so you have to think about this, okay? So there is evolving analgesia. The evolving analgesia, as I said, we started by epidural anesthesia. Okay, epidural anesthesia was not the right thing because you have motor power loss. And then we had the lumbar plexus block. Okay, after the lumbar plexus blocks, we had the femoral nerves, and these all produce motor power loss. So the femoral or sciatic peripheral nerve blocks, there is now decreased use of sciatic and femoral nerve blocks because they fail in participation of physiotherapy secondary to weakness. So alternative techniques have to be developed, as we will see now. So the current trend that you have is adductor canal block. Adductor canal block with or without catheter. This produces analgesia without motor power loss. So as you see, the femoral alternative is the adductor canal block. So before we use the femoral nerve, when you use 3-in-1 block, you have 3 nerves blocks, even though the patient will have good analgesia, but he will have motor power loss, and this will have a problem in that the patient will not be able to be involved in the early physiotherapy. You have to know that there are some centers in the US now, they do knee replacements as a day case surgery. And now we have the adductor canal block. The adductor canal block is what we call the subsartorial block. So if this is the sartorius here, and you have the vastus medialis and the adductor longus, there is a canal under the sartorius. This triangle has the femoral artery, femoral nerve, and the saphenous nerve. The saphenous nerve is purely sensory block, okay? So when you give the adductor and canal block, you will have anesthesia for the knee joint. When you have the adductor canal block, it is a subsartorial injection. The nerves that will be affected is the saphenous nerve, the vastus medialis, and the articular branch of the obturator nerve. But this is the nerve that we're heading for, which is the saphenous nerve. These are studies which shows the femoral nerve block versus adductor canal block. There's 15 studies in the last 3 or 4 years, in 2017, and this showed that the adductor canal block is a very reasonable block, replacing the femoral nerve block, because it has the ability of maintaining the muscle power of the leg. So the patient will be involved in the early post-operative physiotherapy. So these studies, they concluded that the adductor canal block, patients walked further in the first day, second day, on the third day, and the pain score were much lower in the adductor canal block group. And the adductor canal group, more patients were satisfied. But there was no significant difference in the total opioid consumption, because with femoral nerve block and adductor canal block, you have analgesia, equal analgesia. But the advantage of the adductor canal block, that it is a sensory block. The femoral nerve block is a sensory and motor, and this is not acceptable for the early involvement of the physiotherapy. And they concluded that the adductor canal block provides good analgesia with superior ambulation, faster. Something went wrong. Just a minute. See? ده ايه اللي حصل؟ Right. Okay. I think this is the going back again. So as I said, evolving analgesia, you have the epidural, and then we went to lumbar plexus block, and then the femoral catheter or sciatic nerve block. But as I said, this is not what we want. So the current trend now is the adductor canal block, all right? The problem with the adductor canal block, that it does not provide analgesia to the posterior part of the knee. This is very important. So even though the patient will have good analgesia with adductor canal block, it will be only the front part of the knee. This is extremely important. That's why we developed 2 techniques to provide analgesia for the posterior part of the knee, so that the patient will have a complete free analgesia for the whole circumference of the knee. You have to know that the knee joint is very complex when it comes to pain. There are lots of nerve endings. So in order to give good analgesia, you need to have front and back blocks. The front block is the adductor canal block, and the back block is done by the surgeon, what we call surgeon infiltration or IPACK block, and we will go on this one. So I'll try to play the video. So this is the adductor canal block, okay? So this is your probe. You look for the sartorius, and then you're going to inject your local anesthetic under the sartorius, and you will get the saphenous nerve block. Samy, next. So, how many patients would have posterior knee pain? This is very important. When you give adductor canal block, as I said, this is not enough. You need to have posterior analgesia as well. as I said, innervation of the knee joint is so complex, so there is always posterior knee pain. So the surgeon infiltration. Surgeon infiltration, it has been shown that if the surgeons will do the local injection in the knee joints, they use about 100 mils, and their other studies shows a total of 60 mils. Okay, but I think most centers would use 100 mils of local anesthetic and a mixture. They use local anesthetic, ketamine, epinephrine, and epimorphine. Some centers would use ropivacaine, epinephrine, ketamine, and clonidine. And other center would add steroids and antibiotics, okay? But something very important. If you do an adductor canal block, you're going to use 20 mils of local anesthetic. And the patient, the surgeon will inject another 100. So you have to be in communication with the surgeon so that you will not exceed the toxic dose of local anesthetic. So always have a chat with the surgeon. It's better that you prepare the local anesthetic solution for him so that you won't exceed the toxic dose of local anesthetics. So the surgeon infiltration, they have potential side effects, of course, but they are not major. If you put in the mixture steroids, you have the advantage that it is an anti-inflammatory, but you will have hyperglycemia and increased rate of infection. Clonidine, which is alpha-2 adrenergic receptor agonist, it has a good synergistic effect for your local anesthetic and opioids, but on the other hand, there is an incidence of hypotension, bradycardia, EV block, and sedation. Ketamine, they have platelet dysfunction. Morphine, it's good as a central opioid receptors, but you will have the side effects of nausea, pruritus. And the amide, as I said, you have to be in communication all the time with the surgeon so that sometimes, but if the patient is hypertensive, it's not good to put epinephrine in the mixture. Antibiotics, some centers they would use cefuroxime or vancomycin to prevent side effects, but in elderly patients, you might have effects on the renal tissues by the antibiotics. In the US, they infiltrate the knee joints, but what we call the Exapral. Exapral is a slow depot, the pipivacaine. It's a non-liposomal pipivacaine, and I don't think it's common in China or in Europe. It's only in the States. It is a very long-acting depot form of pipivacaine that can last up to 24 hours. So there are some studies that showed that sciatic nerve block, which gives analgesia to the posterior part of the knee, have more or less the same effect like letting the surgeon injecting the local anesthetic in the knee joint. So with the local anesthetic in the knee joint, there is no motor loss. So you have the advantage of involving the patient in the physiotherapy as early as possible. So sciatic nerve now, I don't think any center would do a sciatic nerve or femoral nerve block. So our normal one is an adductor canal block, and you have to give analgesia for the posterior part of the knee. Like as I said, the surgical infiltration by local anesthetic and the IPACK block, which I'm going to explain now. So as I said, this is the current trend. This is what we should do. You have an adductor canal block that blocks the saphenous nerve, so it gives analgesia to the front of the knee, and then the posterior part of the knee, you would need to do two things: surgeon infiltration by local anesthetic, and the new block now, which is called the IPACK block. So what is the IPACK block? IPACK block is injection of the local anesthetic in the interspace between the popliteal artery and the capsule of the knee. Okay? And this is done, of course, under ultrasound machine, and it provides analgesia for posterior capsule of the knee without sciatic motor block. So now we have a patient ready to get involved with the early physiotherapy because he has anesthesia for the front part of the knee provided by the adductor canal block, and he has analgesia for the posterior part of the knee by the surgeon infiltration and the IPACK block. We usually inject 20 mils of 0.2% of ropivacaine, and it blocks the articular branches of the tibial and peroneal nerves and the posterior branch of the obturator nerve and the medial genicular nerve. So I want to confess about one point now. So you injected 20 mils of local anesthetics for the adductor canal block. You injected 20 mils for the IPACK block. This is already 40 mils. So you have to discuss with the surgeon if he's going to do surgical infiltration so that you don't exceed the toxic dose for local anesthetics. So this is the needle. So the IPACK block now, patient will be supine. So you don't need to reposition the patient. And usually when we do the IPACK block, we give it on the lateral, from the medial to the lateral part of the knee. And you inject 20 mils of ropivacaine. So that's so the transducer over the knee. And you inject the local anesthetic. This is the femoral condyle, and you inject the local anesthetic in this part. These are some studies that showed that in group A, patients were subjected to combined adductor canal block with IPACK block, and the other group, patients received only adductor canal block. So patients with adductor canal block, the visual analog score on day 0 and day 1, morning and evening, and they studied the range of movement in the postoperative day and the distance walked on day 1. So they give in group A adductor canal block with IPACK block, and group B adductor canal block only, and they compared in day 1 where the number of steps walked was much higher, statistically significant. So, and because as I said, adductor canal block, they give analgesia to the front part of the knee only. The IPACK block provides analgesia for the posterior part of the knee, so we have the whole circumference of the knee covered by analgesia, and the patient would walk better. There are some additives that you can put in your local anesthetics. Dexmedetomidine, so you do adductor canal block, right, and you add dexmedetomidine in it, and it showed that patient satisfaction was higher in the dex group. And if you do decadron, dexamethasone, you have the duration of sensory block is higher. The morphine use was lower with the dex group. And the pain and with rest and movement was, of course, far less with patients with dexamethasone. And even though they actually measured the C-reactive protein and interleukin-6 with dexamethasone group and the control group, and it showed that the C-reactive protein, the inflammatory mediators, were less with the dexamethasone group. So it's actually when you add dexamethasone, it's something good in your local anesthetic. So we come to the conclusion now that the new techniques are promising for improving care while reducing complications. But it depends on the culture, of course, the surgeons, the expertise to perform regional blocks, and the support you give to the patient. So I want to conclude that, as I said before, the most important thing for knee replacements is the early involvement of the patient in the physiotherapy, because it affects the prognosis of the operation. By doing this, you need to do a block that is more sensory than motor, so that the patient movement will not be affected. And to achieve this in the knee, because the knee is very richly supplied with nerve endings, you need to have a block that blocks the front of the knee and a block to block the posterior part of the knee. To block the front of the knee, you would need the adductor canal block, and the posterior part of the knee, you would need the surgeon infiltration plus the IPACK block. I hope that I was clear in explaining everything. So we finished 5 minutes before the scheduled time, so we can have more time for discussion. At the end, I want to thank very much WeSonic for giving me the chance of sharing my points of views about regional anesthesia. And I am sure that actually VSonic supports lots of countries in the developed countries. They're doing a great job. And as I said, this workshop is provided for free for everybody. So they are putting burden on themselves financially. And but this is our mission as doctors, because the most important thing is to provide the best care for the patients. This is what we're here for. I thank you so much, and I'm ready for any questions.
Okay, thank you so much, Professor Aziz. So next session will be our Q&A, and it's your turn.
Sure.
Professor El-Refai. Yeah, I just saw some questions. Yeah.
Stop sharing. So I'm looking for the questions.
From Yasser.
Yeah. Yasser Top.
Correction. Oxypral.
Yes.
Like
Yeah.
Vivacate can stay for.
Yes, it's true. But minimum 24 days, 24 hours, but can stay up to 3 to 5 days. So you are right.
Most of the
Should
study.
I type it or answer live? I'll answer live. Or shall we type it better?
Is there a difference in the location and type and dose of regional anesthesia during and after total knee replacement?
Is there a difference in the location and the type and those means during? Well, as I said, don't think I can understand this question properly.
Do you mean to start analgesia after the operation?
Now, as you said,
Use ultrasound to see medial inferior genicular artery during knee-related surgery? What the actual clinical significance?
my leader told me that it is essential.
To test
with IPACK, right. With IPACK block, the most important thing is to avoid injury of the popliteal artery. So you look for the space between the posterior part of the femur and the popliteal artery, and then you inject the local anesthetic in between. Okay. Only 3 questions or 10?
Fantastic topic. I enjoyed it.
All right. Is there any more questions?
I have a doubt in the
internal knee. The last one about the microartery.
Which position of the knee do I need to inject drugs to relieve the patient pain?
Where is this question? Chats?
Which position of the knee do I need drugs to relieve the patient pain?
Well, just a minute. It's a fantastic topic. I enjoyed it. I enjoyed it too. Thank you, Dr. Yasser. Carmen, thank you for sharing. I have a doubt in the internal knee. For saying which position of the knee. What is the symptoms of meniscus? What is the symptoms of meniscus injury and inflammation ultrasound? To be honest with you, I don't know the answer for this one.
There are many questions today.
Amazing lecture. You can choose. This is a nice question actually from Rob Muss. Can they advise how to choose between facial anesthesia or nerve block? As I said, the evolution of analgesia is to be more precise. So you need to do nerve blocks rather than facial anesthesia. All right? Yes.
Can the progress of knee
under ultrasound
stage to be judged under ultrasound? He's talking about diagnosis.
My patient is an 18-year-old sprinter. The knee ligament is injured by This is actually a nice question from Mikulaj Pinsvisky. The 18-year-old sprinter, the knee ligament, was injured by the severe sports. The measures that should be taken, you can give him an adductor canal block and an IPACK block, because this will cover the anterior part of the knee and the posterior part of the knee. The IPACK block, we do it before surgical. Okay.
We do it before surgical incision?
Yes. Yes. If joint snapping, you should ask a surgeon, Louisa, for this. Right. So, Odi, do you have any questions?
Yes, I find still some questions in the QA. Like Louisa, they said, is there any better treatment for joint slapping besides
joint what?
Joint slapping? This is the question from Louisa Passos.
Let me check it.
Yes.
Louisa, is there any better treatment for joint snapping besides arthroscopic surgery?
Yeah.
Well, I'm an anesthetist, so I don't think I can answer this question. So you need to ask a surgeon for this one. Yeah.
Okay. Mustafa, he said,
IPACK block before surgical incision? Yes, you can do this. Yeah.
Is right?
Yeah, that's right.
And another one is mycolage.
Yeah. Yes, this is a proper analgesia. You can give for the front of the knee an adductor canal block. You block the saphenous nerve, and then you give him an IPACK block, which will cover the posterior part of the knee. So the whole circumference of the knee will be covered, and this will provide them with a very good analgesia.
Okay. And another Chinese guest.
Yes. I experienced a case of 49-old man.
Yes, knee joint
necrosis combined with gout and obvious tophy, and his knees has been deformed. In this case, what treatment can you use to improve the patient's pain before, during? It's the same. So you have to give him a preemptive analgesia before the start of anesthetics, and an adductor canal block, and IPACK would be the same as well. Because these blocks are purely sensory, so it won't affect his motor power at all. And you can use a catheter, adductor canal block catheter. Well,
Another question: can you put a catheter for
yes,
adductor canal block?
Adductor canal block, yeah. Oh, here, do we need a catheter for adductor canal block? If you want to do a continuous adductor canal block, yes, you can. But most of the centers, they would use just a block and IPACK block.
There is one question from Yasser Tobo. He said, what is the difference of preemptive and the prevention analgesia? And which team is better for pain management? Which term?
Which one? Where is it? What's his name?
Yasser Tobo.
Yasser Tobo. The liposomal PPV can stay up to 3 to 5 days. Yeah, minimum 24 hours.
So it's another, the first one, I think. What is the difference of preemptive and prevention analgesia?
I can't find it.
Oh, you cannot find?
Can't find it.
Okay.
Preemptive analgesia is when you give the analgesia before the surgical insult, okay? So you kind of pre-block the receptors.
Okay. So I think it's almost finished. How about, let me check. The Olga has one question. She said, is there a difference in the location and the type and the dose of regional anesthesia during and after total knee replacement? Did you say this question from Olga?
For total knee replacements, you would two blocks, the adductor canal block and the IPACK block and the surgical infiltration by the surgeon. Okay, so the location is the same. Type and dosage of local anesthetic, usually use pipivacaine, and you do additives. As I said, the surgeon might add steroids, some morphine in it. I don't like morphine because this might induce nausea, vomiting, and this will affect the early involvement of the patient with physiotherapy. So we would stick by local anesthetic and steroids. But as I said, different centers would do it in different ways. Some centers would put antibiotics. Some centers would put steroids with the surgical infiltration. But I think local anesthetics and steroids are more than enough. Sometimes they put epinephrine, but if the patient is hypertensive, this would affect his blood pressure.
Okay. Any other questions? No? But how about
difference between preemptive and preventive analgesia? Ask a surgeon. I think the surgeon would ask this better than me. Okay.
I think he's answered most of questions now.
Yeah. All right.
If no any other questions, I think we can end up our webinar, right?
Yes. Thank you.
Anyway, thank you so much again for your wonderful presentation, Professor Aziz, and thank you so much for your kind assistance, Professor El-Refai. Meanwhile, thanks all the audiences for staying with us all the time. And for more information about ViSonic forthcoming new webinars or the replay of the previous webinars, please kindly follow ViSonic official account at Facebook, LinkedIn, or YouTube. Thank you, and see you next time.
It's my pleasure to introduce our Professor